So we have discussed the community as a unit of care and the various assessment tools that we can use to arrive at a community diagnosis. So what should we do now with the data that we have gathered? Of course, we will start analyzing them. I am Dr. Lynn Redoble. I am a member of PASCOM and I teach community medicine at the Davao Medical School Foundation. But before we go into that, I would like to reiterate that at all levels of community diagnosis, we make sure that the community is with us, or rather, we are with the community whenever we look at the data and analyze it. No less than the Alma Ata Declaration of Primary Healthcare mandated for the full participation of the community. The main reason for this full participation is, of course, empowerment. Because if our ultimate aim is for self-reliance and self-determination, then this is assured by the participation of the community at all levels. On the practical side, the presence and involvement of the community members already validates the appropriateness and acceptability of the analysis, and it also addresses the need for the community's ownership of the coming intervention. So you may ask how many members of the community is an acceptable number for community participation. Of course, a community assembly would be best, but since that's difficult to do, we should make it a point to include those who are most affected, and in community organizing, you can use the core group. So we are now in the third part of the components of community medicine practice, integrating and analyzing the assessment results. After we have gathered our data, we now identify the problems from that data. And what do we usually look out for? The first ones relate to the health of the community, like the causes of mortality, the causes of morbidity, especially contagious diseases or diseases with high mortality, and highly preventable diseases. Then child health, maternal health, reproductive health, and then we look at those that relate to social services like water and sanitation, and the vices that are prevalent in the community. We also look at the availability and utilization of health services, and we also look at the social determinants. So for example, these are the problems that you identified in the data. Be sure to list them in terms of frequencies and ratios in your own notes, because you will need to go back to the actual numbers to see if you have actually improved. But when you present this to the community, you need to simplify the terms. For example, number 3 becomes, instead of 16 of the 29 children below 5 years of age are underweight, you may simplify that to increased prevalence of child malnutrition. Everybody understands malnutrition. Now, this is just an example. Usually, we require the students to list at least 10 problems, but most often than not, there will be more than 10. So once you have a list of the problems, you will need to prioritize which problem you will address. Again, the prioritization process should be done with the community. Therefore, you will need to explain the different criteria to the people. So we rank problems according to these criteria. The first one is magnitude of the problem, which basically means how many people are affected. Then the vulnerability to change, if the problem is easy to change with the existing technology. Then we look at social concern, or the value attached by the community to the problem, or if the problem affects certain populations, especially the marginalized ones. Then we look at the existing health policies, because we can use this to further our interventions. The prioritization matrix looks like this. Now, for example, if you have 10 problems, the people will rank each of the 10 problems according to the criteria. For example, for magnitude, the person and the individual will rank the 10 problems with 10 as the biggest, as the highest rank, and 1 as the lowest rank according to magnitude, and so on for the different criteria. For some people, they say they'd rather have a scoring system. Others say that you need to have a factor that will indicate the weight of each criterion. But I like to keep it less complicated. From each person, we then get the sum of each problem. Then we get the grand total of the ranks given by all the people present. Then we do the final ranking. From this, we can see that problem number 3 garnered the top rank. The next step is the problem tree analysis. Here we will identify the factors and build the cause and effect relationships of all the factors. Now, to avoid putting all the blame on the individual or all the factors on the individual, we use the social determinants of health and the health systems approach in identifying the factors. First, we look at the individual factors. What are the possible genetic and behavioral causes or factors of the core problem? Then we look at the social factors. What are the possible economic, cultural, and environmental causes? Then we also look at health systems. We use the systems-based approach. We look at the leadership and governance like the political setup, the government services available. We look at health financing like payment for health services and budget for health. We look at health workforce or the presence or absence or the adequacy of health personnel. We look at medical products and technologies, information and research, and finally service delivery. This is how a problem tree is done. The core problem, which is your identified problem, is in the middle. Immediately underneath are the direct causes, and under each cause are also their own causes. They are considered indirect causes to the core problem. The arrows proceed from the cause and points to its direct effect. And this is done for each box. So this is an example of a problem tree done for the core problem of increased prevalence of child malnutrition. For this core problem, we have identified two direct causes: poor dietary intake of the children and increased prevalence of childhood diseases. Now, poor dietary intake of the children has two causes: inadequate feeding practices and behaviors of the mothers and insufficient supply or access to healthy foods. The inadequate feeding practices also comes from low supplementation coverage of vitamins, poor knowledge on proper nutrition, and an imbalanced dietary pattern, and so on and so forth. So make sure that your arrows go from the cause towards its effect. To test the relationship, you can ask, if I solve the cause, will it solve the effect above it? For example, if I improve the feeding practices and behaviors of mothers, this will lead to better dietary intake of the children. The next step is to construct the objective tree. To do the objective tree, just go back to the problem tree, and for each box, you reverse the sense. Now, for example, increased prevalence of child malnutrition becomes reduced prevalence of child malnutrition. And poor dietary intake of the children becomes improved dietary intake of the children, and so on and so forth. Now, given the limitations that our students have in fourth year community medicine, we go to further assessment of the causes. The first, so we list all the causes here, all the factors in the problem tree, those at the bottom like poor dietary intake, increased prevalence of childhood disease, inadequate feeding practices and behaviors of mothers, insufficient supply or access to healthy foods, high prevalence of diarrhea, etc., inadequate income, unemployment, etc., etc. And the first step that you do is to divide these causes into those that can be acted upon by the health sector and those that can be acted upon by the other sectors. So, poor dietary intake, increased prevalence of childhood diseases, inadequate feeding practices and behaviors of mothers, and high prevalence of diarrhea can be acted upon by the health sector. But whereas insufficient supply or access to healthy foods, inadequate income, and unemployment needs to be done by the other sectors. Now, take note of these those that can be acted upon by the health sector, because we will now further subdivide them or further categorize them to immediate concern and needs long-term solution, because we know very well that in community medicine 4, our students are only there for 8 weeks. No? So only immediate concern. So among those that we listed that can be acted upon by the health sector, we have the poor dietary intake and inadequate feeding practices and behaviors of the mothers that is considered as immediate. Whereas those that needs long-term solution is the increased prevalence of childhood disease and high prevalence of diarrhea. So again, you take note of the list on the left, no? And then the last step is the setting of the objectives. Here, you just review your problem tree and the objective tree, no? So you look for your core problem, the increased prevalence, for example, increased prevalence of child malnutrition, and then you look for the corresponding objective, which is reduced prevalence of child malnutrition, and this becomes your general objective. And you look for the two causes that you identified in the previous step, poor dietary intake and inadequate feeding practices and behaviors of mothers, and you look for the corresponding objectives in the objective 3, and they become your specific objectives. Like specific objective number 1 is improve dietary intake of the children, and specific objective number 2 is adequate feeding practices and behaviors of the mothers. No? And so, yeah, we have integrated and analyzed our data, and we will move on to the next discussion, which will be on the interventions. Thank you.